Good morning from Miami Beach. This is Dr. John Bennett broadcasting from Neurosurgical TV headquarters. We have the honor of doing a series in microneurosurgery with Dr. Umit Eroglu, MD, a prominent neurosurgeon from Turkey. And I'm going to have Murat Zamoglu, a neurosurgeon, introduce him. Good day, Murat.
Yeah. Good day, sir. It's very nice to be with you in this Saturday evening. And thank you for this opportunity, Dr. John Bennett. Now, I would like to introduce Dr. Ümit Eroğlu. He's working in Ankara University for many years now, and he's a prominent neurosurgeon working in vascular surgery and also robotics neurosurgery, and is also academic person in Ankara University, and my mentor also. And now I would like to ask Dr. Ümit, how are you?
Thank you, Murat. How are you?
Fine, thank you. We're talking with John Bennett and how this is a lovely opportunity for us to meet up and get together with also young neurosurgeons. I'm also a neurosurgeon myself, and I'm working with Dr. Ümit Eroğlu in Ankara University. Now, sir, maybe we can start our presentation, if it is okay, Dr. John Bennett.
Hi, everyone. My name is Ümit Eroğlu, and I work as a neurosurgeon at Ankara University. Today, we will conduct part 2 of the microneurosurgery series. I will try to explain ICOM arterial aneurysm with a minimally invasive supraorbital approach. You know, one of the largest series in the world regarding the supraorbital keyhole approach belongs to our clinic. We have made a video atlas book on this approach this year. You can see video atlas book here. Here I check it. Okay. In this approach, there is no need to shave the eyebrows. You are watching a preparation video regarding the supraorbital approach now. We do not administer fluids to patients, and we give 1 milligram per kilogram of prednisolone. We always perform a lumbar puncture on each patient. This way, we create an extra space between frontal lobe and the dura. I think this is Dr. Murat who did the lumbar punctures.
Yes, it was me in the surgery. And it really helps to navigate from the small opening. When CSF is drained, a larger space is available, isn't it, Dr. Ümit?
We positioned the head extension, hyperextension. You can see now. T-pin fixation is done. A 50-degree rotation towards the contralateral side is sufficient. It's okay. Then we proceed with the surgical steel draping. The patient is given no more than 100 cc of fluid by anesthesia throughout the entire surgery. This ensures brain relaxation until the CSF is drained. You can see there is no need to shave the eyebrows. For aneurysms, if they are not too complicated, the total skin-to-skin surgical duration does not exceed 45 minutes. This provides a significant advantage, especially for elderly and pediatric patients. You can see we notice the supraorbital notch and marked it. The incision should remain lateral to this notch.
I think this is for proximal control, isn't it?
Yeah, yes. This is for proximal control for ICA aneurysms. In this presentation, you will see consecutive videos related to ICOM, arterial aneurysm surgery. You can see steel draping. There are a few important steps that need to be known and applied in this approach. One of them is position, the head in hyperextension. Also, preparation like lumbar puncture are important. But the first target is always optical carotid system. We have to identify optic nerve and carotid artery. The door is open C-shaped. You can see. Now we can see the aneurysm dome. It's very close to optic nerves. We are preparing for temporary clip for the premature rupture. We apply clip contralateral A1. And you can see both A1, both A2, and both pulmonary arteries. Is for this approach. We are not afraid to rupture the aneurysm because we have control of both A1 arteries. And we can easily dissect the optic nerve now. In cases of anterior communicating artery aneurysms, it's often unnecessary to see the carotid bifurcation or opening Sylvian fissures. You know, the carotid artery continues towards the optic nerve as the A1 segment, and that's okay for us. We always check the vessels with Doppler, ICG, or fluorescein. And this is another case. You can see the angiogram, CT angiogram, 3D CT angiogram. CSF training is very important for this approach. The diamond drill tip often we use for this approach. The most important surgical procedure in this approach is drilling orbital roof. You see the door is opened in a C shape and fixed with sutures. In this approach, neurosurgeons encounter an anatomical view that they may not be very familiar with. You can see optic nerve, the carotid artery. We use sharp and sometimes blunt dissection. We don't see the carotid bifurcation. Just A1 is okay. You can see A1, and we follow the A1. The contralateral optic nerve is seen now. The contralateral A1 is seen. You know, sometimes we have to take gyrus rectus, resect gyrus rectus. The most difficult, in my opinion, the most difficult location for these aneurysms is inferior and posterior location. This approach provides the fastest and the shortest route to access this area. I will now check the vessels. It seems okay. You can see all cranial base vessels in here.
Dr. Ümit, I think you are not using any eccartation, like
Yes.
only
Yes.
your aspirator
Yes.
and
I don't
bipolar,
use any retractors. Yes.
no retractors. Very
Yes.
impressive.
CSF training is very important for this surgery. Another case. During inner frontal bone and orbitalis is very, very important steps for the surgery procedures. C-shaped opening. One surgery. And one surgical cutting is enough for this surgery. The first target is always optic nerve and carotid artery. Now we can see the optic nerve. We use the sharp dissection. You can see olfactory nerve, carotid artery. We use always in here sharp dissection. This exposure is enough to find the A1. You can see A1 now, and we follow it. We have to be very gentle. Now we are going to see the others, the contralateral optic nerve and contralateral A1. Sharp dissection. And we can see contralateral optic nerve and contralateral A1 vessels. Sometimes I use temporary aneurysm clip need to be applied. In this situation, it's important to ensure that the clips do not remain in place for than 2 or 3 minutes. The aneurysm dome is attached to vessels, so I apply the temporary clip. I always use intraoperative neuromonitoring for this case. And now I have a gap for clip. This is a Höppner artery. I applied the clip, but it's not good. So I checked it. It's some more manipulation for total occlusion of aneurysm. But there is still neck, and one more clip application is performed. And always we check the vessels 2A1, 2A2, and Höppner arteries. And fluorescein or ICG is our helper tools. This is another case. There is a hemorrhage. Two or 3 centimeter craniotomy is okay for this surgical approach. I try to see orbital roof and using diamond drill tip. Again, C-shape dural opening. And the dura is fixed by sutures. We don't afraid to opening the frontal sinus because we can close it fat pad, periostomy, or cranioplasty. Always first target is optic nerve and carotid artery. Yes, and now we can see optic nerve and frontal carotid artery. We can see now A1 and follow it. You can see hemorrhage, sharp dissection, and sometimes blunt dissection. If there is a hemorrhage, I always open the lamina terminalis. You can see the aneurysm dome, 2A1, 2 Hebner's artery, and 2A2 arteries. And now we check it. Another case. There is a huge ACOM aneurysm. You can see, I always drill orbital roof. So I have an extra space between frontal lobe and frontal dura.
Do you always use diamond tip?
Yes, always.
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 It helps with bleeding, I think, or more
Yes,
controlled drilling.
yes. For hemostasis also.
Yeah.
You can see optic nerve and carotid artery. Sharp dissection. I never open Sylvian fissure for the surgical procedures. Yes, you can see the optic nerve, and I followed the A1 arteries now to find the ACOM. Preparation for temporary clipping. Because this is a giant ACOM aneurysm, and you can see the contralateral Hebner attached to aneurysm dome. I'm trying to find contralateral A1 and contralateral A2, but the aneurysm dome is too big, and I couldn't see the A1 and A2, so I apply a temporary clip for aneurysm dome and try to find contralateral A1, and yes, there is a rupture. But we don't have it because we have proximal control. And applied blind clip and then check it. It seems good. As you can see in all videos, I don't use retractors, Murat. In any of case, there is no need for them. Instead, I cover the visible part of brain with Surgicel and continue with surgical cutting. This approach helps protect the brain tissue and provides a clear field without the potential complication associated with retractors.
Yes, I think it's very advantageous not to
Yes.
use retractors, and you'd never disrupt the natural anatomy of the patient.
Yes.
Only
It's very
CSF drainage and drilling of orbital roof is more than enough, as I can see.
Yeah.
You have a large surgical field.
Yes.
I understand. Dr. Ümit, thank you for this wonderful presentation, and
you.
the cases you showed us are very interesting actually, and there are some like ruptures, and you manage them also. I'd like to congratulate you.
Thank you.
Dr. John Bennett, now I think we can take questions, or
Yes, please.
dear participants, if you have any questions, you can ask them from the text window. Feel free to ask anything.
Generally, people are a little shy, as we've seen.
Yeah,
But
yeah, of
yeah,
course.
don't worry about it. Don't worry
Yes,
about it. We're just in
don't
an
worry about it.
informal academic atmosphere. Go ahead. You have a comment?
Normally, people are afraid to ask any questions in this like academic presentations. They don't want to be like the one sticking out
Yeah,
asking
I was the
questions.
same way. I would hide in the back. That's what I would do.
Yeah,
But it's with the digital age, I find it much easier to talk. But anyways, do you have
of
any
course.
questions, Murad, at all? Any comments on his presentation?
There
Okay.
are two people raising hands.
Oh, good. Okay, I'm missing them. Okay, great.
Yeah.
I'm
From the
missing them.
participants menu, there are two people lifting hands for
Yeah,
questions.
could you read those questions, please? And
Of course, but they're just like raising hands, but
can you see the questions or no?
Yes,
they didn't.
Vikram Shakya asks, how long do you usually apply temporary clip? I usually 2 or 3 minutes apply temporary clip, not more than.
Okay. Elif Goldcap writes, thank you so much for this insightful presentation. The detailed explanation of the supraorbital approach and its minimally invasive benefits was really impressive. I have a question based on your experience. How do you decide between a supraorbital approach and a more traditional craniotomy for ACOM artery aneurysms?
Thank you, Elif. In my opinion, after 10 years, it is a gold standard. Okay, it's a gold surgical procedure for me for all anterior cranial base pathologies. It's now for me, it's a gold standard.
Okay, very good. Amro, do you see Amro's question? Let me see here. Amro, you're in the Amro, I see you have a question. I guess you can ask it. I made you let you talk, Amro. You want to ask a question or you want me to?
I have one question.
Go ahead.
This is Dr. Amro from Ethiopia. And I
Oh,
have one question. When
Ethiopia.
do you
Hey, all
do?
right, Ethiopia.
Hello
That's
Yeah.
great. That's great.
Yeah.
from Ethiopia. Very interesting.
Okay.
Please
When do
go
you
ahead
do
and
this
ask your question.
surgery after? Okay.
Go ahead. You want to ask a question or a comment? Perhaps not. I think he fell off because of bad connection.
When do you do the surgery after
Oh, there you
aneurysmal
go.
run? Hello?
Yeah, go
Sorry,
ahead.
I didn't catch it.
Go ahead.
Hello?
Go ahead, Amro.
Hello.
Yes.
When do you do this your clipping and
I'll tell you what, Amro, can you write your question and we'll ask it? Just text it. Okay.
the interval between surgery time? The
Yeah,
interval.
please text
Are you
your
hearing me?
question. Text your question. Your connection's not great. Text it, please.
Okay. I will forward.
Okay.
Dr. Amro, because of internet connection, I think your voice is like not fluent. We cannot understand it. So if you can write it in the text, then we can discuss about it.
Okay, there you go, Dr. Amro. We got your name, your text right there. You guys can see the text, right? I think he's writing his question now. Go ahead, write your question, Dr. Amro.
They want to ask, when do you operate post-hemorrhagically, I think?
Oh, okay, there you go. When do you do your clipping after an SAH?
How many days, like how many, when to operate after subarachnoid hemorrhage?
Yes.
They are usually, I didn't catch it, but they are usually, we usually operated urgent surgery in 6 hours after subarachnoid hemorrhage.
And if you get to it quicker, you want to get to it quicker, right? If you can or no?
Yeah.
The earlier the better, I guess.
Okay.
Yeah, the early is better.
Okay. Very good. It's good to hear you from Ethiopia. Come back more often. Okay. Any more comments or questions from the panelists?
There are not any more questions, Dr. John Bennett.
Yes. Looks like we'll wrap it up and get ready for number 3.
Yeah.
Yeah, Dr. Bennett, thank you for providing us.
Okay. Thank you very much for presenting
Okay,
and
thank you.
and basically enlarging the knowledge of the neurosurgical community.
Thank you.
Okay.
Thank you.
We'll see you
See you.
guys next week.
See you guys. Thank you.
Bye-bye.
Bye bye.
Bye bye.
Stop here.